Good evening. Welcome to tonight's installment of our Cancer Health Education webinar series, Gynecologic Cancers, Prevention and Treatment. I am your host, Natalie Evans, Community Relations Marketing Specialist with Franciscan Health. We look forward to sharing some useful information on the basics of gynecologic cancer. This evening, our expert will help you better understand what is gynecologic cancer and its risk factors, which screening tools are available, what are the most common cancers in women, which treatment options are available at Franciscan Health. But first, I'd like to share a few housekeeping items. Everyone is muted upon entering the virtual event. We ask that you keep yourself muted to help us avoid background noise and interruption. If you have questions to ask the presenter during the presentation, please enter them in the chat window. We will address those questions after the presentation. Our awesome administrator, Kirsten, is taking care of everything on the back end. So if you experience any technical issues, just type them into the chat window to be resolved. If you miss anything, don't worry. We will send out the on-demand recording in a follow-up email. If you would like to schedule an appointment with our gynecologic oncologist following the presentation, please contact your primary physician to receive a referral. Franciscan Health is home to some of the country's most well-respected physicians and clinical specialists. With that being said, I am excited to introduce you to Dr. Ayeni, gynecologic oncologist with Franciscan Physician Network Gynecologic Oncology Specialist. Dr. Ayeni specializes in treating early stage as well as the most advanced and complicated cancers, including cervical, ovarian, vulvar, and endometrial cancers. She is board certified with the American Congress of Obstetricians and Gynecology. Dr. Ayeni received her undergraduate degree in biomedical engineering sciences from Harvard University and earned her medical degree from Mayo Clinic College of Medicine in Rochester, Minnesota. Dr. Ayeni completed a residency in obstetrics and gynecology at Duke University Medical Center in North Carolina and a fellowship in gynecologic oncology at the Mayo School of Graduate Medical Education. She has been with Franciscan Health since February 2016 and serves our Indianapolis campus. Dr. Ayeni became a gynecologic oncologist because she enjoyed confronting mortality and always wanted to give patients hope. She is the practice leader at Franciscan Health Cancer Center, Indianapolis, and one of the only surgeons to use minimally invasive surgery, including Da Vinci robotic surgery. In addition to fighting cancer, Dr. Ayeni is a full-time mother to 2 young girls and a boy. They enjoy going to concerts, taking long walks on the canal, and biking. Before we get started, I would like to know a little bit more about you. Let's start with our first poll question. Why are you attending this webinar? A, I have a form of gynecologic cancer. B, gynecologic cancer runs in my family. C, I want to know how to detect gynecologic cancer. It looks like 13% of you have a form of gynecologic cancer. 13% also have gynecologic cancer in their family, and others just want to know how to detect gynecologic cancer. So I appreciate your participation. We received a variety of responses. Now, without further ado, please welcome gynecologic oncologist Dr. Tina Ayeni as she discusses the risk factors, screening, and treatment options for gynecologic cancers.
Thank you, Natalie, for that introduction, and thank you all to the participants who are taking time out this evening to join us for our presentation. When we hear the word cancer, it's such a big word. Let's just take a moment and pause to think about what exactly is cancer? Well, as you can see in the top frame, normal cells are uniform in nature. They align right next to each other, and it's very organized. But in contrast, tumor cells are abnormal growths of cells. They are irregularly shaped, abnormal in their pattern of growth, and kind of unpredictable in terms of how they're going to grow and whether they're going to travel from where they have started. So this abnormal collection of growing cells can be benign. Benign growths often can be removed and they're not going to come back. That's the definition of a benign tumor. In contrast, tumors that are cancerous are ones where the benign growth has the ability to come back. So even when we have a malignant group of cells, we can remove it, but they still always have the ability to come back and have the ability to become life-threatening. So that's how cancer is defined. And even though it is an abnormal collection of tumor cells, you can also have benign tumors that are also abnormal collections of cells, but those are different from cancer. So we're going to talk about the cancers that are originating in the female pelvis, the uterus, the fallopian tube and ovary, as well as the cervix. In 2020, 1 million women in the United States received a diagnosis of cancer. The majority of these women had breast cancer, lung cancer, and colorectal cancer. But in the top 5 list of common cancers, uterine cancer is number 4, affecting about 7% of those women receiving a new diagnosis. Let me just pause for a moment just for a technical check here. Kirsten, are our slides viewable?
Yes.
Okay, fantastic. So let's keep going. In terms of the other female pelvic cancers, ovarian cancer barely makes the top 10 list of most common cancer diagnoses in women in the United States. And cervical cancer has become a rare cancer in our country. About 1.5% of women receiving a cancer diagnosis last year received a diagnosis of cervical cancer. In contrast, women are dying from, again, lung, breast, and colon cancer, but ovarian cancer, which barely was, or I would say ovarian cancer was one of the least common diagnoses, but it is in the top 5 in terms of cancers leading to death in women. Uterine cancer, number 6, and cervical cancer farther down the list at number 13. So when we think about cancer, one of the first questions that comes to mind is, what can I do to avoid getting some of these cancers? So let's define a risk factor. A risk factor is something that can either increase or decrease your chance of developing a disease. So examples would be lifestyle, exposures in the environment, smoking, tobacco. Those are risk factors that can increase risk for certain cancer development. For men and women, as you get older, by getting older, your risk factor for cancer goes up just based on age. And then for most cancers, if there's a family history, that alone can also be a risk factor for developing disease.
We've learned some great information, but before we continue, let's do another poll question. Which of the following factors will increase a woman's risk for gynecologic cancer? A, having HPV, B, smoking, C, a family history of breast, gynecologic, or colon cancer, and D, all of the above. Let's see those responses. The answer is D, all the above. It sounds like all of you are learning a lot of great things and had the correct answer, so thanks for being engaged.
So we know what a risk factor is. What about a screening test? This is going to be a really important topic that we're going to keep bringing up throughout the presentation. So a screening test is something like a mammogram, a pap smear, or a colonoscopy. It's a test that we give to patients who feel healthy and don't have concerning symptoms. The whole purpose of a screening test is to see if we can find either an early stage cancer or, even better, cell changes that are still in a pre-cancer phase. So the benefit of a screening test is you're healthy. We want to see, is there any concern or evidence that there's a cancer that's trying to develop? So we'll keep bringing up that theme throughout our talk today. Let's start out with endometrial cancer. This is a patient of mine, 58 years old. She had gone into menopause about 5 years prior, so no bleeding whatsoever for 5 years. And then she all of a sudden started to experience vaginal bleeding. She had the standard workup, a pelvic ultrasound to look at the uterus. That showed that the lining of the uterus was overgrown. She had a pap smear to evaluate her cervix. The pap smear was okay. They didn't find any abnormalities there. So she ultimately underwent a biopsy of the endometrium, and that confirmed a grade 3 cancer arising in the endometrium. My next case is a younger patient, 27 years old. She shared with me that she had had regular menstrual cycles once a month up until about 6 months prior to when she came into our office. Since that time, she'd been having irregular menstrual cycles, very heavy, lasting unpredictable lengths of time. So her workup started very similarly. She had a pelvic ultrasound. It showed that the lining of the uterus was, somewhat thick, but maybe not overly concerning for a young woman. Her pap smear was normal. She ultimately got a biopsy of the endometrium, and she also was diagnosed with an endometrial cancer. So endometrial cancer, it's actually a disease of older women. The average age of onset is 60. It is the most common cancer that I see as a gynecologic cancer surgeon. About half of all female pelvic cancers in the United States actually start in the endometrium. But luckily, it's a cancer where there are symptoms. Over 90% of women will have bleeding, either bleeding for the first time after going to menopause or having irregular menstrual cycles. So the fact that there is bleeding that's irregular is an early warning sign. And for that reason, the majority of time, we find these cancers at stage 1, and our cure rates are over 90%. So let's just talk about the anatomy. The endometrium is highlighted there with the yellow triangle. It's the inside cavity of the uterus. Before menopause, this tissue grows every month to prepare and support a pregnancy. If there's no pregnancy, that tissue sheds off and gives a woman her period. So every month before menopause, this lining builds up, sheds off, builds up, sheds off. Once you are in menopause, that lining is no longer active, and so there should be no bleeding as a result. So when women have abnormal bleeding, that's why one of the first questions we have as physicians is what's going on with the endometrium? And that's why we get ultrasounds to help evaluate whether that tissue is too thick or if it's normal size and nice and thin. We diagnose endometrial cancer with the biopsy. This can be done in the office. We call that an endometrial biopsy. Pictured here, it's essentially a pelvic exam, and it takes about 10 seconds. We put a really thin instrument through the cervix and into the cavity of the uterus, and we can collect cells with that maneuver. Sometimes we go to the operating room and we do a procedure called a D&C, and that accomplishes the same thing as well, getting a sample of that endometrial tissue so that we can get the diagnosis. As I said before, bleeding is an early symptom and usually allows women to kind of raise the alarm to their doctors, and we find most of these cancers early in the game. As you can see in this picture, these cancers start in the center of the cavity, but the whole goal is to grow through the wall of the uterus. And ultimately, these cancers want to actually exit, leave the uterus, and spread to surrounding structures. Luckily, most endometrial cancers are caught when everything is confined right within the uterus. So there are certainly risk factors, and these are risk factors that we have an opportunity to modify. Too much estrogen in the system is the leading cause for development of endometrial cancer. So let's go back to what we know about normal physiology. Before menopause, your ovaries make estrogen. That's the hormone that causes this lining to grow every month to prepare for a pregnancy. So when a woman goes into menopause, the ovaries are no longer functional. They're no longer making those high quantities of estrogen. And that's why the lining of the uterus stays nice and thin, and there's no more bleeding. But guess what? There are other cells in the body that can also make estrogen, and those cells are fat cells. So if you are overweight, fat cells in the body are also making estrogen. And sometimes if you're overweight, there's too much estrogen in the system. And that's how the lining of the uterus can be stimulated. And over time, that continuous stimulation causes those cells to transition from normal to precancer and then to cancer. There's a condition that I see in young women called PCOS. Essentially, that's a condition where the hormones are not balanced and there's too much estrogen exposure coming from your ovarian hormone supply. That excess exposure of estrogen causes that lining to overgrow and start to transition into precancer and cancer. So that's probably the leading cause for most women with endometrial cancer. Some women have a family history, not a common cause for the development of endometrial cancer. If I take 100 women with endometrial cancer, about 5 of them would have gotten their cancer because of something that they inherited from their mom or dad. There are 2 conditions that are commonly known: Lynch syndrome and Cowden syndrome. These are syndromes where you inherit mutations in genes. You inherit those from your mom or dad. We'll talk about those more later in the talk. But if those genes don't work well, it increases the development of certain cancers, such as endometrial cancer. And then, believe it or not, there are some medications that can increase the risk for endometrial cancer. Tamoxifen is a medication that some women are on after being treated for breast cancer. And there is a slight increased risk for endometrial cancer with that medication. But then hormone replacement. Some women, after they go into menopause, they may choose to take hormones to treat hot flashes. Well, if you're not careful about the balance of your estrogen and your progesterone, sometimes you have too much estrogen acting in your system, and that also can lead to endometrial cancer. So there are risk factors. Here we go with screening. So I talked earlier about the fact that screening is a test that we can do to see if a woman has maybe an early cancer or precancer. Well, we don't screen all women for endometrial cancer. And the reason that we don't is because it's actually a rare tumor. The average US woman's risk for endometrial cancer is only 3%. That's pretty low. But for women who are at increased risk for development of endometrial cancer, yes, we do recommend screening for those specific women. It's a small group of women, but their risk can be as high as 60% in their lifetime to get an endometrial cancer. Those women who have increased risk are those women who have the genetic conditions that I mentioned earlier. And for those women, we start their screening around the age of 30, typically an ultrasound and that biopsy of the endometrium. We do those once a year. So how can we prevent endometrial cancer, and who should be counseled about prevention? Well, the easiest way to prevent getting endometrial cancer is to take out the uterus. That's a hysterectomy. And we do recommend that, but only for those women who are at significantly increased risk. Again, those women with a genetic condition. We usually recommend the hysterectomy after they're done having their children or around the age of 40. So just a small population where we would try to do a preventative hysterectomy. So there are 2 types of endometrial cancer. I've pretty much talked about the type 1 version. That is the most common. If you take 100 women with endometrial cancer, 85 will have the type 1. Slow growing, very good cure rates, usually stage 1. But the other 15 women will actually have a more aggressive version. We call those type 2 endometrial cancers, and they can be serous, clear cell, or high-grade histology. These type 2 cancers are a little bit of a conundrum. We actually don't know what the risk factors are for those diseases, but they are problematic because they are very aggressive. They often will present at advanced stages, and because of that, they are very difficult to cure. Estrogen does not play a role at all in the development of these rare forms of endometrial cancer.
Dr. Ayeni is sharing a lot of great content. Let's test your knowledge with another poll question. Treatment options are determined by the following: A, the stage of cancer, B, a desire to have children, C, the woman's age and general health, D, all of the above. Let's see those responses. Perfect. Most of you had the correct answer. The answer is D, all the above. We appreciate your undivided attention. Back to you, Dr. Ayeni.
Thanks, Natalie. So treatment, surgery is the dominant treatment approach for endometrial cancer. We usually approach it through small incisions, as you can see in this background photo. The Da Vinci robotic system is a system where we make small incisions that are about the length of a fingernail. And through those incisions, I put the arms of the robot machine, and then I use the computer to move the robot arms around. That's how we detach the uterus, the ovaries, and sometimes the lymph nodes, as you can see in this picture here. Certainly, some women need more than just a hysterectomy, and that can include radiation, chemotherapy, or immunotherapy. I would say for the majority of my patients, if they need treatment beyond surgery, it's typically radiation. The top photo shows external beam pelvic radiation. This is painless. Basically, this beam goes across your pelvis. It sterilizes all of the tissue, and that helps to prevent cancers from recurring in the same area where we originally had the cancer develop. Even more common is something called vaginal radiation or vaginal brachytherapy. That's pictured in the bottom photo. This is a vaginal cylinder. It goes in the vagina and it delivers radiation to the vaginal tissue. That helps to decrease the risk for cancer coming back in the vagina, which is the most common location for these cancers to come back after we have done surgery. So let's transition to cervical cancer. I have a case of a 58-year-old female. She presented with postmenopausal bleeding and had a very standard workup. Again, pelvic ultrasound to look at the uterus. The uterus looked okay. We did an exam and we clearly could see an abnormal mass on the cervix. We did a biopsy and that confirmed cervical cancer, specifically squamous cell cervical cancer. My other patient, younger in age, 27, she'd been having some bleeding between her periods, complaining of bleeding after sexual activity. Her workup included, very similarly, a pelvic ultrasound, which showed the uterus looked okay. The cervix looked normal, so we did a pap smear, and that actually confirmed presence of cancer cells. Adenocarcinoma, specifically those cancer cells were located higher up in the cervix. We'll come back to that when we talk about the anatomy. A little background: cervical cancer is a rare cancer in the United States. It used to be the #1 cancer that we saw in our country. And currently, it is the most common gynecologic cancer in the world. But it's also the most preventable of all of the gynecologic cancers. And how did the US go from this being #1 to being a rare cancer? You remember in 2020, 1 million women were diagnosed with cancer in our country. Only 1% of them had a diagnosis of cervical cancer. That's because of pap smears. Pap smears are an excellent screening tool. They are excellent in detecting precancer cells and even some early cervical cancers. So it's because of pap smear screening that cervical cancer went from #1 to being rare in our country. So let's look at the anatomy. There are really two parts to the cervix. When I think about the cervix and the uterus, I think about a light bulb. The silver portion of the light bulb corresponds to the cervix, and that's the bottom part. The outside lining is called the ectocervix. That's the part that I can see during a pelvic exam. But the cervix also has a canal, and that internal component, we cannot really see that with the naked eye. But cancers can start inside that canal, or they can start on the outside. And women have symptoms with cervical cancer, oftentimes abnormal bleeding, such as bleeding after sex, bleeding between their periods, so intermenstrual spotting is what we would call that, and maybe an unusual smelling discharge. We diagnose cervical cancer through a biopsy. and that can be done in the office. Generally, if we can catch cervical cancer early, the prognosis is very good. Over 90% cure rates for stage 1 and 2 disease. Risk factors. We know what causes cervical cancer. 99% of them are due to a viral infection. That virus is called HPV, human papillomavirus. This is actually the most common sexually transmitted infection in our country. It's not like other sexually transmitted infections. Gonorrhea, chlamydia, women are usually going to have symptoms, or oftentimes, I guess I should say, will have symptoms like discharge. HPV doesn't cause symptoms, so you don't really know if you've been infected unless we test for the presence of those particles during your pap smear. So HPV infection is so common. The majority of women in the US have been exposed to this virus. But the thing is, your body knows how to get rid of the virus. So even though many women are exposed, not all of them develop cervical cancer. And that's because the women who get cervical cancer are those where the HPV infection cannot be cleared from their system. If you have persistent infection with this virus into your 30s, that's the biggest risk factor for development of cervical cancer. So that's the answer to the first question there. Can the virus be treated? No, it can't. I don't have an antibiotic or any other medication to give you to get rid of the virus. The only way to get rid of HPV is through your own body's immune system. So just like when your young child goes to the pediatrician and they have a runny nose, mild fever, and your pediatrician says, well, you know, just got to ride this out. I don't have an antibiotic. That's because it's a viral infection, not a bacterial infection. Antibiotics treat bacteria. Your body treats viruses generally. So even though I cannot treat the virus, the HPV vaccine works to make your body's immune system very smart, so that if you get exposed to the virus, your immune system can get rid of it even better than if your immune system had not received the HPV vaccine. So that is the benefit of the HPV vaccine. It basically makes your immune system strong enough and gives it a higher capacity to get rid of the virus. The HPV vaccine is exceedingly effective. It prevents cervical cancer 97 to 100% of the time, and is currently approved in our country for girls and boys aged 9 to 26. Who needs screening for cervical cancer? You might recall that for endometrial cancer, the only patients that we screen are those who are at the highest risk. Cervical cancer is different. Everybody needs to be screened, all women. How do we do that? Well, it takes a pelvic exam once a year. And then a pap smear at different intervals of time. Usually we start doing pap smears at the age of 21. And for the first decade, girls, women should get pap smears every 3 years. Starting at age 30, we should do the pap smear and the HPV test every 5 years. These intervals of time, they seem pretty long, but research proven that this is the most effective strategy for identifying the majority of cervical cancers. I think an important take-home point in this slide is that even if you're not due for a pap smear, you still need to see your doctor for a pelvic exam. Every woman, every year of her life needs a pelvic exam. I have diagnosed cervical cancer, rectal cancer, ovarian cancer, just based on a pelvic exam. So this is an absolute must. And if we don't remember anything else from the presentation, please remember, if your doctor is not offering you a pelvic exam, you need to either ask for one or just keep your gynecologist. I think gynecologists are awesome, of course. You should have one, even if you're not having babies anymore, because they do pelvic exams all the time, and they certainly will give you a pelvic exam every year as indicated. So can we prevent cervical cancer? Absolutely. As I said, we've done an amazing job in our country preventing this disease. Unfortunately, women still get cervical cancer. So what can we do to prevent it? What can you tell your friends and family? Well, don't smoke cigarettes. Tobacco weakens your immune system and it prevents your body from being able to get rid of HPV as easily. Secondly, it is a sexually transmitted infection. So using condoms, avoiding multiple sexual partners, those are strategies to help decrease being exposed. Getting the HPV vaccination, as I discussed, is highly effective in preventing cervical cancer in 97 to 100% of cases. And then, of course, the pap smears to help detect primarily pre-cancer. So if we can catch pre-cancer cells, we can treat those easily by removing those and preventing those cells from ultimately becoming cancer. The treatment for cervical cancer, the majority of women are treated with radiation. There's only a small population of women who are good candidates to have radical surgery. So when I'm doing surgery for cervical cancer, it's usually for tumors that you can barely see. And when we do the hysterectomy, it's not a regular hysterectomy where we are hugging the uterus and the ovaries close. The type of hysterectomy for cervical cancer generally is a radical hysterectomy. That's where we take out the top inch of the vagina and all of the fatty tissue that surrounds the uterus. In terms of radiation, it's very similar to the type of radiation that I talked about for endometrial cancer. Radiation is highly effective for the treatment and cure of cervical cancer. So some women are cured just with radiation alone. And typically we give a little bit of chemotherapy because that makes your cure rates even higher. So let's transition to ovarian cancer. And let me just take a moment to discuss the fact that ovarian cancer actually includes a family. Cancers that start in the ovary, cancers that start in the fallopian tube, and cancers that start actually in the lining of your belly cavity called the peritoneum. So when I counsel my patients, I talk about the fact that, your bowels, they slosh really easily. They don't stick to the underside of your belly wall. And the reason for that is because there's like a saran wrap layer of tissue that lines your abdomen and is very thin. But that thin lining can become cancer in women. And when it becomes cancerous, it looks just like ovarian cancer, and we treat them the same. So I use the term ovarian cancer, but really I'm talking about three entities: cancers that start in the ovary, cancers that start in the fallopian tube, cancers that start in the peritoneum lining. They're all present similarly, look the same underneath the microscope, and we treat them the same. So I had a patient, she was 60. She had been having about 8 months of progressive, kind of just worsening back pain. She thought it was her original back pain. She was getting worked up with MRIs of her spine, going to a chiropractor. She ultimately got a CT scan, and this is what it showed: a large mass in the pelvis. This was her ovary. Normally an ovary is about an inch in size. This was stage 3 ovarian cancer when we did her surgery. Looking at the anatomy very quickly, the ovary has 3 compartments, and cancer of the ovary can start in any of these 3. Sometimes cancers start in the egg sacs. We call those germ cell cancers. Sometimes cancers start in the actual muscle of the ovary. We call those sex cord stromal. But 95% of ovarian cancers actually start on the skin of the ovary. We call those surface epithelial tumors, such as serous, mucinous, endometrioid. In a nutshell, when you hear about ovarian cancer on television, many of the Hollywood stars, like Angelina Jolie's family, when they talk about their experience with ovarian cancer, this is the kind of ovarian cancer we're talking about. 95% of women, their ovarian cancers start on the skin. And for the most part, most of these women are in their 60s. And the majority of women, unfortunately, present at stage 3 or stage 4. The majority of women, when they present, the tumor has left the ovary and has spread to the upper abdomen. A structure called the omentum is commonly involved. That is that yellow draping of tissue that you can see in the photo. It's kind of like a fatty tissue as a curtain that covers the bowels, and it doesn't have much of a function. But ovarian cancer loves to spread to the omentum. And oftentimes, for my patients, this tissue structure is replaced by cancer. Because most women are at advanced stages when they present, most women, it's difficult to cure. Ovarian cancer is the #1 cause of death from gynecologic malignancies. Interestingly enough, we used to call ovarian cancer the silent killer, but there's been a lot of effort from our Society of Gynecologic Oncologists to get the word out to the media, to newspapers, to our population, that ovarian cancer has symptoms. It's just not necessarily ovarian pain. The symptoms that most women describe is bloating. They feel full quickly when they're eating. They have back pain, like my patient who had 8 months of just kind of this worsening back pain that she thought was her standard back pain. But, after we learned her diagnosis of ovarian cancer, she said, you know what? The pain was different from my typical back pain I'd had for years and years. I would say the most common symptom in this list, though, is frequent urination. Countless number of my patients will report to me that in the months leading up to their cancer diagnosis, they were being treated for urinary tract infections. Maybe they get a course of antibiotics, they'll feel better, but then those urinary symptoms would return. Maybe they got treated with antibiotics again. So I hear that a lot. And a study done on women with ovarian cancer found that that was the number one symptom, frequent urination. So there are symptoms and there are risk factors. Genetics plays a huge role in ovarian cancer, more so than the other female pelvic cancers. So if you have a family history of ovarian cancer, a personal history of breast cancer, or if you have a known genetic mutation, those are all factors that can increase your risk for ovarian cancer. So let's take a step back and think about the forest as opposed to zoning in on the tree. Ovarian cancer is rare. The average US woman's risk is only about 1%, exceedingly rare. But if you have some of these genetic risk factors, your risk can be as high as 40%. That's significant. So like I said, genetics plays a huge role in ovarian cancer. So let me just kind of break that down a little bit. DNA is in your bloodstream. You inherited that from your mom or dad. Your DNA houses all of your genes, and your genes basically determine your eye color, your hair color, how tall you're going to be. But some of those genes also act like policemen. They know how to see abnormal tumor cell growth, and they know how to prevent it from becoming cancer. So believe it or not, you actually have genes in your body that can prevent cancer development. But if those genes don't work well, we call that a mutation. And you can inherit those mutations from your mom or dad. So some of those genes that are supposed to suppress cancer, if they do not work well, that increases your risk for cancer. And bad genes is the explanation for almost 30% of ovarian cancers. Significant. Only 5% of endometrial cancers are due to bad genes. A third of ovarian cancers are due to bad genes. And this is just a list of some of the genes that we know about that when they don't work well, they increase the risk for ovarian cancer to various degrees. So these hereditary syndromes, I would say the BRCA syndrome is the most commonly talked about, the most commonly known, but Lynch syndrome also is something that you can inherit in your family, and that can increase your risk for ovarian cancer. So who needs screening? You remember how I said cervical cancer, all women should be screened, but uterine cancer, only women at highest risk, the genetic risk factor should be screened. Ovarian cancer is similar. Only those women with a genetic condition need to be screened. And the way that we do their screening is with a pelvic ultrasound, a blood test called a CA-125, and we start this around the age of 30. We can prevent ovarian cancer by taking the ovaries out before cancer can develop. And we do absolutely recommend that for women who are at the highest risk. Again, those are women who have a known genetic condition because their risk is so high. The average US woman does not need to have her ovaries out. Her risk for ovarian cancer is only 1%. Your risk for complications from surgery is about 1%, maybe a little bit higher. So that's the reason why we don't recommend taking everyone's ovaries out. We only take out the ovaries in those women who are at the highest risk. Their risk can be up to 40%. We want to get those ovaries out before ovarian cancer can set in. Unfortunately, because the majority of women, over 80%, present with disease that has metastasized or spread far away from the ovary, the survival is poor. About 30% of these women will live to 5 years. The way that we try to treat them is with surgery and chemotherapy. You need both. You cannot control ovarian cancer with surgery alone. You cannot control it with chemotherapy alone. You did need both strategies. And more importantly, you need a gynecologic oncologist as your surgeon. Studies have shown that the better your surgery, the better your survival. So this slide is just a summary of multiple studies through the 1990s and early 2000s that looked at this. The green bars show women with ovarian cancer who had surgery and all of the visible tumor was removed. The red bar shows those women with ovarian cancer who had surgery and they still had tumor left behind that was up to 2 centimeters in size. The blue bar represents those women with ovarian cancer who had surgery and they had tumor left behind that was bigger than 2 centimeters in size. Who lived the longest? The green bars, the women who had all of the tumor removed. This is a specialty surgical skill to know how to navigate the abdomen and pelvis with ovarian cancer. And for that reason, you need to have a gynecologic oncologist on your team.
Thank you, Dr. Ayeni, for sharing your expertise and teaching us so much about gynecologic cancers. But before we move on, let's do one more poll question. Minimally invasive surgery involves fewer incisions, reduced pain, and a quicker recovery time. A, true. B, false. Those responses. A majority of you guys said true, and the answer is A. The statement is true. Back to you, Dr. Ayeni.
All right, thanks, Natalie. So this was a study that was published in 2013, and it actually made the New York Times front page. Essentially, they did a study in California and found that about less than 50% of women with ovarian cancer were actually receiving care with a gynecologic oncologist. So you can imagine if women don't have a gynecologic oncology specialist on their team, they may not be getting the right surgery, and that can impact their survival. Surgery is important, but so is the chemotherapy. How does chemotherapy work exactly? In a nutshell, it damages the DNA in the cancer cells. And cancer cells do not know how to repair DNA damage very well. So if the cells cannot repair their damage, they die. And that's how chemotherapy can be effective in treating cancers and killing off cancer cells. So one of the stories about ovarian cancer is that it's the rule of 80s. 80% of women present with advanced stage 3 or 4 disease. With chemo and with surgery, we can get 80% of women into full remission. But unfortunately, over 80% of those women will also find that their cancers grow back. That's a really hard aspect about ovarian cancer and really challenges the ability for us to cure this disease. But I wanted to highlight one of the groundbreaking treatment strategies that really has come into our practice in the last 2 years, and that's something called PARP inhibitors. So you'll remember that I said chemotherapy damages DNA. If the cancer cells cannot repair that damage, they die. And how do cancer cells repair the damage? They repair it with a protein called PARP. But we have medications now, tablets by mouth, that block PARP. We call them PARP inhibitors. So if PARP repairs the damage in the cancer cells, if I can block PARP, then those cancer cells stay damaged and they eventually die. So what we have found is our aspirin a day keeps the cancer away. This picture depicts the study that was groundbreaking. Women with ovarian cancer had their surgery and chemo. Half of them got nothing after they were done with their treatments and went into remission. And on average, their cancers came back in 15 months. The other half of the women got the PARP inhibitors. They took those tablets every day for an average 3 years, or 2 to 3 years, after they were done with their chemo and surgery. So they got into remission, they started taking their tablets every day. And for the majority of them, after 4.5 years, the cancer had not yet grown back. Huge. It's a renaissance period in terms of the treatment of ovarian cancers. And you can get these therapies here at St. Francis Cancer Center. let's open the floor up for questions.
Yes. Now we would like to take some time to answer any questions you might have for Dr. Ayeni regarding tonight's presentation. Please type your questions in the Q&A chat box. I will read them aloud and Dr. Ayeni will provide a response. Let's see what we have. First question, if you had postmenopausal bleeding, then all the tests came back normal. Is there a need to do a repeat of all the tests after a few months?
That's an excellent question. It depends. Definitely if the bleeding comes back, you kind of start back at square zero and the whole workup needs to be reevaluated. And in those situations, sometimes you need to pursue a hysterectomy. If there isn't an obvious explanation like a benign polyp, or sometimes the bleeding is actually not coming from the uterus, it could be coming from the vagina. If you have dry vaginal skin, which a lot of women in menopause experience. So I think it's a better question of what do you think your doctor thinks is going on? We call that, a differential diagnosis. That's a medical term. It basically means, what is the list of possibilities? Do I think this is actually just dry vaginal tissue, or am I concerned based on the ultrasound that there might be something hiding that I can't get to? So it's a complex answer, but I think there are different scenarios where yes, you may want to do a follow-up ultrasound, or maybe nothing else is indicated.
Thank you. This is great. We're really receiving a lot of great questions. The next one, I have PCOS. I have had 3 successful pregnancies. However, with PCOS, I am still confused on the differences between having more estrogen versus having more testosterone. I have the typical symptoms: excess facial hair, high cortisol, and hair loss. I thought these were all symptoms of high testosterone. Can you please clarify this?
Yeah, so PCOS is a spectrum. And so that means that it's not exactly, it doesn't look the same in every person. Some women have no excess hair, they have regular periods every month, and you'd be surprised that they have the diagnosis. Other women struggle with not getting periods every month. A more classic thing that I see in my world is some women with PCOS, because of the hormone imbalance, they're not having a regular period every month. Maybe they're having a period once or twice a year. And because of that imbalance in hormones, that's what's predisposing them to getting a uterine cancer. So it's a spectrum, and not all women have the same symptoms, even though they have the same diagnosis.
All right. The next question. If you have had a hysterectomy, do you still need a pap smear?
Yes, for some women, no, for some women. So generally, if you have a hysterectomy and everything was benign, so a lot of women get hysterectomies just for heavy bleeding or painful fibroids, for example. If they have had regular pap smears for the 20 years before their hysterectomy, you don't need pap smears anymore. So let's say you started your pap smears at 21 and here you are at 45 and you're getting a hysterectomy and all of your pap smears have been negative, HPV negative. When you get your hysterectomy at 45, you don't need a pap smear, but you still need a pelvic exam every year. If you are 32 and you're getting a hysterectomy, you probably haven't had 20 years of pap smear screening. Even though your pap smears were normal between age 21 and your hysterectomy at 32, you still need to get pap smear screening after your hysterectomy.
All right, the next question. What are the symptoms for reoccurrence of endometrial cancer, and what's the survival rate?
The most common symptom is bleeding, vaginal bleeding actually, but other symptoms include pelvic pain or pressure. Sometimes women can develop a mass in the pelvis right where the uterus used to be, and that may not present with bleeding, but you might have the pressure, the pain, you might have frequent urination or painful bowel movements. Some women have bloating even. And then sometimes if endometrial cancer comes back, it comes back in the lung. That's actually not uncommon, and some women can develop a weird cough where you don't feel sick, you're not coughing up any sputum, but you have like a dry cough that doesn't go away and just hangs around. That can be a sign of endometrial cancer recurrence. The risk for these cancers coming back depends on whether we caught it early stage or advanced stage. So for my patients who are stage 1, the cancer was only in the uterus, the risk for it coming back is as low as 6% in the majority of those women. For women who are stage 3, where the cancer, when we found it, it had already spread to the lymph nodes. We can cure about 60 to 70% of those women, but it can come back in about 30% at the same time.
All right. Do women age 75 and over need to have a pap smear performed? And if so, how often?
Generally not, but in order to stop getting pap smears, right now, the most current recommendations are you can stop at the age of 65 if your preceding 20 years of pap smears have been normal. So that means you need to have been coming in regularly between age 45 and 65 in order to stop getting pap smears. But my take-home point for the whole presentation, even if you're not getting a pap smear, you still need a pelvic exam every year, even if you're over the age of 65. And a pelvic exam means your doctor places the speculum. Well, first they look at your labial tissue on the outside, external exam. They place the speculum into the vagina. They look at your cervix. And then they do an internal exam where they actually feel the vagina. You can feel the uterus and the ovaries, and a rectal exam, which is commonly done after the age of 40 for sure. And then certainly if you're younger, if you're having symptoms of some sort, you need a rectal exam as well. So that is the female pelvic exam, and it needs to happen every year, just like just like the men in our families get their prostate exams every year. Women, we need to be making sure we're getting our pelvic exams.
Thank you. Yes. The next question, what about squamous cells in the vagina after a total hysterectomy?
I'm sorry, can you repeat that question, Natalie?
Someone asked, what about squamous cells in the vagina after a total hysterectomy?
Squamous cells in the vagina. So the vagina has 2 cell populations that can develop precancer or cancer. They have cells that we call squamous, and they have cells that are, well, we call them adeno cells. So if you have squamous cells in the vagina, I guess the question is, is there more to it? Or is it squamous cancer? Because you can definitely get vaginal cancer. Squamous cells are not typically in the uterus, but they do exist in the cervix. So sometimes if you've had a hysterectomy for cervical cancer, the most common form of cervical cancer is squamous cell cancer of the cervix, but the vagina also has squamous cells. So if I had a patient with cervical cancer in the past, maybe we did a hysterectomy to treat it, and she's having abnormal squamous cells in the vagina, one of my questions would be, is this a recurrence of her cervical cancer? So it would definitely launch a specific workup. But again, the vaginal tissue itself has squamous cells, so sometimes those cells can transition on their own.
If a pap smear test is positive for HPV, what is the next step?
If the pap smear is positive for HPV, generally, so it can go a couple different ways, but generally the next step is a colposcopy. And that is a special pelvic exam where the doctor uses a microscope and vinegar. The medical term is acetic acid, but that sounds scarier. Vinegar basically is used, we swab the cervix with it, and it helps to make abnormal cells look bright white underneath that microscope that the doctor is using. So basically, it helps the doctor to see, okay, where did the abnormal cells come from that could be causing your HPV to be positive? And then we would do a biopsy to see if there's any precancer or cancer to explain the HPV.
All right. The next question, would you mind explaining what a cold knife cone biopsy is?
So oh yeah, go ahead.
Go ahead. Okay. What is needed for potential high-grade cells from HPV?
So a cone biopsy is a big biopsy of the cervix. In the office, the biopsy I can do is just a pinch of tissue. And when you see that tissue, it's about the size of an eraser on a pencil, very small. A cone biopsy is indicated if you already know that you've got precancer and you're trying to treat it, you're trying to like scoop it out. So cone biopsy is like a bigger biopsy, is triangular shaped, but you get a specimen that's about an inch in size, so much bigger than just an eraser head. And that's how you can actually effectively scoop out the precancer that you know about and basically help a patient to get her cervix back to a baseline normal healthy tissue. Sometimes we use a cone biopsy though to not only treat the precancer, but also to make sure there isn't any cancer that's hiding. There was a second part to that question, Natalie. Can you repeat that again?
Said what is needed for potential high grade cells that may have occurred from HPV?
Yeah, so high grade cells, typically we can treat those, and a cone is one way to treat that. Basically a scooping out procedure, just scoop it all out. Take out the abnormal cells, take out some surrounding normal tissue, and yeah, hopefully your pap smears will be normal after that. The other word for a cone biopsy is a leap. A leap is basically used with a laser, and a cone is used with a scalpel. So just different tools that we use, but it accomplishes the same thing.
All right, we're getting a lot of great questions, guys, and we're kind of getting close to time, so I'm going to just have a few more. Next question. I've been told that tamoxifen increases my risk of uterine cancer. I know the normal risk is very low. Do you have numbers on the percentage of the increase in this risk?
Yeah, so basically the average risk is 3% in our country. If you're on tamoxifen, that risk increases to about 5 to 6%.
All right. Is there any relationship between having HPV in your 30s and later having cancer?
Okay, so that's a good question. I think, you know, a woman can be exposed to HPV at any point in her life. A lot of younger women tend to be more sexually active. That's one reason why we don't test for HPV when women are between the age of 21 and 30, because it's so often positive, but most of the time your body clears the virus. So that's why in that first decade of screening with pap smears, we only do a pap test. After the age of 30, most women don't have as many sexual partners. They're not getting as exposed. And so the amount of HPV infection goes down. But, and that's why we start testing for HPV after the age of 30. Now, any woman can be exposed though for the first time. Some of my patients, you know, have been divorced and remarried and they get exposed with their new partner, or, you know, maybe you just have a new sexual partner later in life and you can get exposed and then start having abnormal pap smears for the first time in your life. And yes, ultimately, over time, if those abnormal cells are not found and treated, it can become cancer.
All right, we'll take about one more question before we have to wrap up for this evening, but you will receive a survey following this presentation, and there will also be an email address included, so you can send your questions there as well. So final question, what are your thoughts on uterine ablation for fibroids?
Oh, let's see, uterine artery. Let's see here. So I'm going to assume that question is uterine artery embolization. And then or maybe they're talking about endometrial ablation. So let me talk about both things. Basically, one way to treat fibroids is to cut off the blood supply. If you don't have a blood supply to a fibroid, it actually will shrink with time. And if you're having any symptoms from that fibroid, a lot of times the symptoms can go away. So that's a procedure that the radiologists do. They basically will make an incision in your groin, and they will get into your blood vessels that you can kind of feel your pulsation right in your groin. They can get into that blood vessel and basically put a little coil in the vessel that feeds the uterus, and that blocks the blood flow to uterine fibroids, and they can get smaller and you can get better from your symptoms. A very safe procedure, effective, and is definitely an option that we counsel patients about. And just for people who don't know, fibroids are benign tumors that can grow in the wall of the uterus. They're highly common. I think over 40% of women have fibroids of varying sizes. But there's another procedure, and I don't know if the question is asking this, but it's called endometrial ablation. Basically, you'll remember endometrial cancer starts inside the cavity. Sometimes women have abnormal bleeding. Maybe they'll get a biopsy and there's no precancer, no cancer. They're just having abnormal bleeding. And one of the ways to make that better is to actually destroy that lining of the endometrium, basically burn it off. That way, only minimal tissue grows every month, and your periods are much lighter, your bleeding is much better controlled. So we call that endometrial ablation. It's very common. It is highly effective. If you are over the age of 45, I would probably avoid it, to be honest, as a cancer professional speaking freely, because the thing is, once that lining has been burned, if you're older in age, the question is, well, is there something stimulating that lining? And even if your biopsy is negative, I would probably try to look to other alternatives that can treat bleeding. Because when the lining is burned, if you have recurrent bleeding at 51, 50, 49, it may or may not be due to precancer or cancer. You know, as you get older, your risk factors for cancer goes up, and it becomes harder to assess what's going on with the tissue once you've undergone that procedure. So I think it's an excellent procedure for young women who have heavy periods. Once you're over the age of 45, you're starting to march towards menopause. Most women go into menopause at age 50. You can have some irregular bleeding for those years. There are ways to control that without an endometrial ablation. And, you know, as a cancer specialist, we see women who have a very compromised workup because they've had that procedure later in their reproductive years. It just makes it harder to know what's going on. And sometimes people need to have surgery, maybe unnecessarily.
All right, I'm sorry that we can answer all of your questions. These are a lot of great questions. We'll just take one more. This person says, I'm 67. My mother died of ovarian cancer at the age of 80. Would you ever recommend removing ovaries for a woman at my age? Great question.
Yeah, that is a good question. And I think a fairly common one. So the general answer would be probably not. But if your mother had ovarian cancer, sometimes you are a candidate to get genetic testing. And the criteria is not a laundry list. You know, we have a very extensive genetic counseling group here at our cancer center. And any woman can actually present for genetic testing. Insurance companies cover it for a majority of cases. And I think the out-of-pocket costs, I don't want to be wrong, but I have had many patients who sign up for that because it can be not as high as you might think, you know, if your insurance company says no. But the ability to get your genetic testing done is so much easier now in 2021 than even what it was in 2011. That is the key to knowing what your risk is. If your genetic testing is negative, just having a family member, your risk probably isn't 1.3%, which is the average woman's risk. It might be closer to about 4 to 5%. And that's where we talk about risks and benefits, you know, because your risk is maybe slightly above baseline, but it is not a standard recommendation to get the ovaries out just because your mother had ovarian cancer. Patients who come to me for that consultation, I try to delve deeper. I try to see, have there been other cancers in the family? Sometimes women have been diagnosed with stomach cancer. You know, if you have older family members, maybe you've heard of a great grandmother, a great aunt who was diagnosed with stomach cancer or a female cancer. You know, a lot of times those are cancers that probably were metastatic ovarian cancer. And so we count that in our counseling. Once you have more than one relative, that's when, you know, your risk continues to increase above that 5%. And we start thinking, okay, maybe we take ovaries out to reduce your risk. So I would generally say, even for the genetic mutations that are not BRCA, you know, BRCA, your risk for ovarian cancer can be as high as 40 to 50%. But there are other genes you might remember that I showed on the slide. Generally for those other genes, if the risk is above about 5 to 6%, that's when we start actually recommending having your ovaries out. So having one family member may not bring you to that level of risk, which is why I say that's a conversation.
Well, great questions, everyone. If we were unable to get to your questions today, please submit them to seminars@franciscanhealth.org. And thank you so much to our clinical expert, Dr. Tina Ayeni, for sharing with us this evening. And thank thank you to all our attendees for participating in the Gynecologic Cancers Prevention and Treatment webinar. We know your time is valuable, and we're glad you prioritized your health today. Once again, we will send you an email with the recording of this session. Feel free to share it with others who may also find it helpful. You will receive a survey and supporting documents related to this webinar and its content. Your feedback will help us make future webinars better, so please take a few moments to fill that out. Thanks again for being with us. Have a blessed evening.